Ferrari.
Thank you very much, Joe. It's a pleasure to be here and to introduce a few words about the Wanamaker Memorial Lecture. This is the 37th Memorial Lecture in honor of Louis Wanamaker, who was the scientific mentor of Dr. Kaplan, myself, and others. He was with our department for over 30 years and then died unexpectedly close to his 60th birthday in 1983. He was nationally and internationally known for his work in the prevention of rheumatic fever, really heroic work that gained him quite a reputation of epidemiologically and the basic science aspects of group A streptococcus. At a personal level, we miss him still because of his wisdom, his great integrity, generous personality, and interest in the department and in all of us. And so I will now let Dr. Edward Kaplan, emeritus professor in our department, take over and introduce Dr. Huskins.
Thank you, Pat. Yeah. Thank you, Pat. Let me first welcome Charlie to our grand rounds. Okay, there we go. Now, as he returns here, Charlie graduated from the University of Minnesota Medical School in 1986. I initially met Charlie at 2 a.m. and people wonder about why that was. It turns out I was on sabbatical in Europe, and Jim Moeller, who most of you know, called me at 5 o'clock in the afternoon here, which was 2 o'clock in the morning in Switzerland, and introduced me to Charlie, who had an American Heart Association grant, and Charlie spent a year in our laboratory working with streptococci. He published 4 papers and abstracts in less than a year as a medical student. In one of his studies, he carefully examined 5,233 strains of Streptococcus salivarius, looking for inhibitory substances against strep pyogenes. And it was clear even then that Charlie was going to be a star. Following medical school, Charlie did his residency and fellowship at the Children's Hospital in Boston, and worked with John Goldman, who is the top of the heap, as we say, with hospital epidemiology. Charlie has many honors and works on many committees and groups, and has risen to the top of the heap. I could go on mentioning numerous other appointments. Suffice it to say, he's among the outstanding clinicians and academic physician scientists in pediatric infectious diseases, both nationally and internationally. Finally, it gives me a great professional and also personal pride to introduce to you the 2022 Louis Wanamaker Memorial Lectureship, Dr. Charles Huskins. Today he will discuss one of his favorite topics, one which he has national and international expertise. So Charlie, welcome home, as they say, and we look forward to hearing what you have to say now. And as long as you don't mention Streptococcus salivarius, you'll be okay.
So thank you very much, Dr. Kaplan, for that wonderful introduction. Thank you for Dr. Ferrari for your remembrance of Dr. Wanamaker. And thank you, Dr. Neglia and the department for inviting me to this presentation. As Ed said, it is a coming home kind of feeling. This hospital wasn't here when I was here before, but to just be back on the U of M campus is a delight and a privilege. And again, I'm very honored by the opportunity to speak to you today. Don't seem to be advancing. I'm not advanced. I'm sorry. Hold on. Just a moment. All right. There we go. Okay. Thank you. So this is a picture of Dr. Wanamaker, and comes from a memoriam in the Reviews of Infectious Disease. And it's meaningful to me because when I was in the lab working with Dr. Kaplan, I'm pretty sure he had this photo on his desk or on the wall. And it was an inspiration to all of us. I've listed, as Dr. Ferrari has mentioned, his numerous awards, outstanding. He was a giant in the field. And his influence was very evident. And his legacy was one that I was a beneficiary of. So if there's one thing I can wish about this conference today too, is that all of you as junior members of the faculty have opportunities to do investigation and pursue things that are life-changing. And this truly was a life-changing event for me. So again, thanks, Dr. Kaplan, for getting up at 2 o'clock in the morning and talking to me and having me as a member of the lab. So these are my disclosures. So there's 3 learning objectives today. The first is to identify new insights into the transmission of respiratory viruses in healthcare settings. I know we're all tired of COVID-19, but we've learned things, and we need to make sure that we recognize those lessons and also understand the challenges and the things that we need to do moving forward in order to be able to address new pandemics and new problems. Secondly, just as human genomics have enabled us to have insights into the causes of human disease and treatments, our ability to more characterize the genomes of bacteria has really helped us be able to characterize the transmission of bacteria in healthcare settings, and then also ways to prevent that from happening. And then finally, Dr. Kaplan asked me to speak a little bit about antimicrobial resistance and stewardship. And I chose to do that by talking about some innovations in study design that I've had an opportunity to be a part of, which I think are very useful and important as we move forward with ways to prevent antimicrobial resistance. So we'll start with transmission of respiratory viruses. And in doing so, I'm going to do a little history here, because I think in order to understand where we are today and why we are here today, it's important to understand that history. So that the history in many ways begins here in 1934 with this publication by Dr. William Wells, who was at the Harvard School of Public Health. And he was involved, his work was looking at respiratory droplets, and he characterized what he called droplet nuclei. So as you can see in the graph on the right-hand side, what he was doing was examining the falling time of droplets, which was on the y-axis, and then in relation to their diameter, which is on the x-axis. And large droplets, which are shown on the right-hand side in the red box, which are greater than 0.1 millimeters or 100 microns, tend to fall to the ground before they evaporate. Small droplets, which are shown in the gold rectangle on the left side, less than 0.1 millimeters, tend to evaporate before they reach the ground and form what was called droplet nuclei. This means that there's a particle there that's minus the water, which is evaporated, but there is still some component of what was there at the beginning as a part of that droplet, which might be a microbe. And these droplets can remain suspended in air for extended periods of time and travel on air currents. And it's important to note that actually Dr. Wells proposed 0.1 millimeter or 100 microns as the threshold between the large and small droplets, which is shown by the interface between the red and the gold rectangles. Now, as to summarize kind of where this led us today, this is a very useful publication that kind of goes back through all the history here. And what they point out is on the upper right side in the blue box is what we have today, our current concept of how things work in terms of transmission of respiratory infections. Dr. Wells' publication is here in the red circle. And as you can see, it's a somewhat complicated and convoluted path from there to where we are here. Important in that path is some additional studies that were done by investigators looking at various respiratory diseases, including TB, but also including non-infectious respiratory diseases like silicosis. And they were really trying to study the size of droplets that can get down into the lung and cause a pulmonary disease. And they came up with the measurement of less than 5 microns, which were able to penetrate deep in the lung, which was different than what Dr. Wells had proposed as the difference between droplets and droplet nuclei. Nonetheless, those two concepts kind of were merged together and came together in our current or historic dichotomous model of droplet versus airborne transmission. And as you can see, droplet on the left side, airborne on the right side. So with droplet transmission, the concept was these were large respiratory droplets, which were greater than 5 microns. Remember, that's a bit smaller than what Dr. Wells had proposed. They're generated by coughing and sneezing. They travel 1 to 2 millimeters and then are deposited because they're large and they settle out. If somebody are generally deposited in the upper airway, and a medical or surgical mask should be sufficient to interrupt the spread for those droplets. On the other side, airborne transmission involves the small droplet nuclei, less than 5 microns, generated by vigorous coughing or what we now call aerosol generating procedures. They can travel much farther than 2 meters and remain suspended for a considerable period of time, and are deposited in the lower airway and alveoli. N95 respirators or powered air purifying respirators are necessary for prevention of these transmission. And then air handling is important too. Negative pressure relative to the hallway, greater than or equal to 12 air exchanges per hour, and exhaust to the outside or through high efficiency particulate air filters. So that was the model. That was the model we had for many decades. Still, to some extent, is the model. But there's some issues there. But along the way, again, a little bit more history here, this model seemed to work. And I show you this example of droplet spread from large respiratory droplets, published by Dr. Ralph Feigen, and his co-author was Dr. Carol Baker, both of whom are former Wanamaker lecturers. And they studied an outbreak of invasive group C meningococcal disease in an elementary school classroom. And kind of astoundingly, there were 5 cases shown in the table on the left all girls, all in the same class, all with serious meningococcal disease over the course of 6 days. And there were actually 2 additional cases, cases 6 and 7, that were the siblings of case 5, so within a family. So as you can imagine, this must have been an incredibly traumatic event for the school. The research team in Texas kind of sprung into action and wound up culturing all the children in the entire school over a single day. And then did an initial analysis of who was colonized with meningococcus, and specifically who was colonized with the group C meningococcal strain. So that data is showed on the right side in the table with the room numbers, the number of carriers, and the number of students in the class. And then they measured the distance from one seat to the next. So that the idea was from one nose to the next in terms of distance. And room A9 was the room where the 5 cases occurred. There were 3 additional children in that classroom that were colonized with the group C meningococcus. And when they did, the distance between chairs was lowest in that room, and about 80 centimeters, so less than a meter. And when you went out from there, the colonization, not only with group C, was much less likely, but colonization in general is much less likely. So this kind of, and actually an additional point here is that the classrooms in that room were boys on one side, girls on the other side. So in fact, the girls were all sitting together on the one side of the class, all in the kind of the middle of the group. So you can see this kind of makes sense for a large respiratory droplet spread. As another example, we have this report of an outbreak of measles at an international sporting event. And we can thank our illustrious Minnesota Health Department for their investigation of this event. They demonstrated transmission in 3 settings: the opening ceremonies in a dome stadium, which many of you will recognize is no longer in existence, but also then at track and field events and first aid stations. And they also identified 8 secondary cases who had exposure only at the opening ceremonies. And I forgot to say the index patient was present at the opening ceremony and actually incubating the disease at that time. With some further analysis, they realized that 2 of the secondary cases were sitting in the same section of the upper deck, which was a full 30+ meters from the entrance to the field where the index case was walking. And with some further analysis, they could understand that the probable situation was that airflow from the fans that were needed to support the stadium's dome was the likely transmission from the index case on the field up to those secondary cases in the second. So again, a great example of something that's a true airborne spread. But as we move forward in time, there began to be some question about, well, what about influenza and respiratory viruses? Is it really just only droplet? Could it be airborne, or is it some sort of combination? In the 1960s and 70s, community studies of influenza had demonstrated high attack rates, 20 to 60% among household contacts. And the question was, well, is that just droplet, or could there be some airborne involved there as well? There were also 2 outbreak reports that were really explosive outbreaks of influenza in enclosed spaces with poor ventilation. The first was in an airplane that was grounded in Alaska in the wintertime. And so they were recirculating the air throughout the plane while they were waiting for 3 hours. 72% of the passengers were infected within 3 days. And then another example of a naval cruiser where 42% of crew members were infected with influenza over a very short period of time. 2000s brought us SARS and MERS, and SARS was the original SARS-CoV-2 virus. MERS was Middle East respiratory syndrome. The key thing there was that we then began to realize that infection in healthcare workers was related to exposure to aerosol generating procedures. So the idea of these small aerosols that might get transmitted to healthcare workers. And then of course the influenza A H1N1 pandemic, which because of its rapid and very widespread distribution, raised the question of, much like we think about with COVID, is there more than just droplet transmission here? Could there be airborne transmission? And then one thing that was not so apparent to many clinicians and healthcare epidemiologists was that there really was an accumulating scientific evidence that indicated that dichotomous model that I presented just a second ago was really insufficient to describe the size and distribution or dispersion of respiratory droplets. Because of that, we began to think, do we need to protect our healthcare workers better? In other words, do we need to use N95 respirators versus surgical masks? And this was a non-inferiority randomized controlled trial done by a group in Canada. They examined the use of surgical masks versus N95 respirators that were worn by nurses when providing care to inpatients with febrile respiratory illness. They did the study in EDs, medical and pediatric units in 8 Ontario hospitals in 2008, and the primary outcome was lab-confirmed influenza by PCR or a 4-fold rise in hemagglutinin titers. The vaccination rates were not good, as you can see, but comparable between the two groups. It was not a large study. There were 225 subjects in the surgical mask group and 221 in the N95. You can see 50% were in the ED and then a quarter each in medical and pediatric units. And again, this is an individual randomized controlled trial. So it's individuals that are either wearing one or the other masks. That's important in just a second. And laboratory confirmed influenza was virtually identical between the two groups. So not a clear signal here that we needed to do anything more than surgical masks. But some of the concerns continued to percolate and through various discussions and publications. And so another trial was done later in the following decade. It's called the RESPECT trial, which stands for Respirator Protection Effectiveness Clinical Trial. And it was instead a cluster randomized trial of outpatient settings. So that means that an entire cluster of healthcare providers in that area would all use the same mask during a period of time. And that's to reduce contamination that might occur if individuals are randomized. Also, it helps to control for the fact that there may be transmission within the cluster. So an important advance in terms of design. And again, they studied N95 respirators and what they called medical masks. These are worn by staff caring for adults and children with respiratory illness. And they did this during 12-week periods, which represented the kind of peak influenza time over 4 successive years. And so individual units would be randomized to either the two masks during those periods of time. So, really a pretty robust design. It was a large study, 1,900 participants in 189 clusters across 7 healthcare systems. So a geographic representation as well. Their primary outcome was, again, similar to the previous study, laboratory confirmed influenza by PCR or a 4-fold rise in hemagglutinin titers. Vaccination rates were better, not perfect, but better. And I'm sorry for the perhaps maybe a little bit hard to read, but the primary outcome is in the upper part, right-hand box in red, and then the secondary outcomes are shown in gold in the bottom box. You can see up in the right-hand corner of the red box, the confidence intervals cross 1. So there was no statistical difference between N95s and medical masks. In fact, the risk was a little bit higher with N95s, a little bit surprising. There was a trend there, but still no clear difference, and all the secondary outcomes did not show any clear difference as well. So you see by the date on the publication, 2019, important date, the pre-COVID date. And so that's kind of where we sat at the beginning of the COVID outbreak. Now, I mentioned that there were other studies going on, and I've chosen just to represent this with a picture rather than going through individual studies, but it's meant to illustrate some points about what we were learning about aerosol clouds that could be generated by respiratory events like a sneeze. So this is a nice picture, and if you want to see the videos, they're listed there. They're quite interesting. But it shows a woman with a sneeze, and these are kind of more advanced optical techniques that were used to kind of quantitate what happened. So you see here in the red frame box, the sort of end result of the sneeze, this sort of fully formed cloud. And then as you move forward in frames, you see it starts to move off a bit. It also starts to diminish, probably consistent with evaporation, as well as some settling. But then what you see also is there's this persistent little, not so little, cluster of droplets that seems to persist. And if you look at the video, you'll see that this really actually can persist and travel out multiple meters, up to 7 or 8 meters away. And these probably represent more finer droplets that are not settling within the 3 feet or 6 foot range. So then as we're moving through COVID-19, we're seeing more evidence that support the role of these kinds of aerosols in transmitting SARS-CoV-2. We had the experimental and modeling studies, which I just showed you an example of. In addition, there were outbreaks in restaurants, on buses, in hotels, and among choir members in closed environments with poor ventilation, not necessarily having everybody within 3 to 6 feet. People were more spread out, but still there was considerable spread in that environment. There was viral RNA in ventilation systems and air samples that was of hospital rooms that was detected, and a nice study from a hospital in Boston where they used whole genome sequencing to define a cluster of cases that occurred in the hospital with staff, and even with WGS, we're able to then identify the 2 staff were infected with the strain that was causing infection in the hospital. In other words, it didn't come from the community, it came from the hospital, and they were using surgical masks and eye protection. And then continued evidence that SARS-CoV-2 infection among healthcare workers could be associated with aerosol generating procedures. So the mask recommendations, which were developed by CDC and WHO, are shown here. They're still in place. For aerosol generating procedures, it was recommended to wear a particulate respirator like an N95, plus other personal protective equipment. And that was the case for both CDC and WHO recommendations. And then there was a little bit of a difference in the situation in terms of caring for patients with suspected or confirmed COVID-19. CDC has continued to recommend particulate respirators and other PPE with a proviso that medical masks are acceptable for routine care when the supply of respirators is severely limited. The WHO has taken a little bit more of a permissive approach or a slightly different tack to say that medical masks or particulate respirators are used if ventilation was known to be poor, cannot be assessed, or not properly maintained. You can imagine there's many places like that. That's not an unusual phenomenon, or based on healthcare worker values and preferences and the perception of what offers the highest protection. So this is where we sit, and we'll talk a little bit more about this in a moment. These recommendations were generated out of concern based on the science, some of the science that I presented to you, but also, for lack of a better term, the abundance of precaution as we have learned to come used to. And just note that obviously if you're using a particulate respirator, there needs to be fit testing and seal check for respirators. And then if you're using a mask, to reduce air leakage around the medical mask. So what is an aerosol we talked about aerosol generating procedures. What are these? CDC and WHO have both defined what they regard as definite aerosol generating procedures, as well as those that are possible. The list from CDC and WHO are quite similar. Notably though, possible it also indicates high flow oxygen or nebulization. That's mainly not because they couldn't be high risk in concept, but because there isn't as much data to support that. Lots of other groups began to define other procedures that they thought were potentially aerosol generating. So you'd see quite a large list of different procedures here. But what's important here is that there are some additional studies, which in interest of time, I'm not going to go into, but I'll just summarize, where people have looked at how much of an aerosol is actually generated by some procedures. And for instance, so there's been some anesthesia studies that have looked at intubation or bronchoscopy. And for simple procedures that go straight forward, no coughing, it's simple, in and done. In fact, there's very little in the way of aerosols that are generated in that procedure. Conversely, I have concerns about high flow oxygen and nebulization, which oftentimes can generate coughing, and whether that is maybe something more to be worried about. The sum total is that what we've done is we've defined the procedure rather than the risk. That's the thing. And so, and you could say that that's a matter of convenience, but I think as we move forward, we need to do a better job of, rather than a laundry list, having something that's really actually more risk-based as opposed to just procedure-based. Point for the future. I show you this. This is a new study just published a few months ago, just to illustrate some of the points about protection here. And this was an experimental study, not a clinical study. It looked at N95 masks and HEPA protection from an aerosol virus, not SARS-CoV-2. They used instead a bacteriophage, which is listed there, and were able to then sample that from body surfaces. They looked at different kinds of PPE, barrier protection of gowns, gloves, and face shields, and then various mask configurations. And then they also tested HEPA filtration, which had 13 filtrations per hour for the room. And then they sampled virus exposure by swabbing the face underneath the mask, in the nostril, and then on forearms, neck, and forehead. So an experimental study. And I will point out, this is kind of an extreme experimental study, because they conducted it in a room with no ventilation. It was a closed room, and the volunteers sat there for 40 minutes. So really probably a bit supra physiologic test, but nevertheless interesting. Anyway, so the room layout for experiment 1 involved the aerosol generator, which is at the head of the bed there, and then a volunteer who was sitting in a chair about a meter to the right of the generator. And then and then they tested various experimental conditions with different kinds of masks. For the second experiment, they installed the mobile HEPA filtration, which you see in the bottom left-hand side of the room, and then had the volunteers sit in 2 different spots, one within a meter and one about 3 meters away from the bed. So these are the results from experiment 1. So just now PPE with different kinds of masks, no HEPA filtration. The graph shows at the top, or excuse me, on the y-axis are the virus counts that were the plaques that they could see from the bacteriophage on the plates. And the pink part at the top shows essentially too numerous to count in a sort of semi-quantitative way of 2 plus 3 plus 4 plus. So that's a large amount of virus. And then they did replicate experiments. Each line is an individual experiment. And you can see there's some variability from one to the next. Looking under A, comparing control versus surgical versus N95 mask, that was not, that failed fit testing. I'm sorry, I didn't mention that in the previous slide. So there were N95s that failed fit testing, and then an N95 situation where that was passed fit testing. You can see the N95s seem to do better than any of the others. Excuse me just a second. The battery on my computer is running low, so I'm just going to plug it in. Sorry for that. In experiment number 2, you see the effect of HEPA and distancing. And it's clear here that there's a contribution that HEPA is contributing here in terms of enabling the now this is just the fit tested mask to demonstrate very, very small amount of virus, both under the mask and in the nostril. Now, I don't want you to walk away from this study that Dr. Huskins is saying that everybody needs to wear N95s all the time. That's not the point. The point of this is to just illustrate the combination benefit of a high filtration mask and air handling that together can really reduce the potential burden. Again, this was a bit extreme as an example of an infection, but illustrative nonetheless. So we've talked about masks for healthcare workers, but the other key part of this too, that we learned, was that we need source control. This is part of infectious disease that we do every day, is there adequate source control? And this is another nice video that shows a person who's coughing and the kind of particles that are generated. And on the right side, you can, in the video, you can see that the masks really limit any further generation of particles. The N95 works better than the surgical mask. There's a little leakage around the surgical mask, but it generally just goes up as opposed to out. So source control is important. That was demonstrated here in this hospital, which I think was the Mass General in Boston, where they looked at positivity rates for healthcare workers in the before universal masking for healthcare workers, which is the pink, after universal masking for healthcare workers in the purple, and then when universal masking was initiated for all patients, and improvement in terms of the positivity. So recognize also there is evidence that seropositive, that what we're doing standardly still has, it can help and it can work. It's not like necessarily everybody need to be wearing N95s all the time. This is a seropositivity study that was done in Emory that demonstrated that demographic and community factors were more higher risk than exposure in the workplace, that working with an infected healthcare worker was a greater risk than caring for infected patients, in part because we know that healthcare workers would tend to take masks off when they were away from the bedside, that ED and COVID focused units were not at increased risk versus non-COVID units, and RT and OR staff were not at risk versus other staff. And I think, I'm not sure what your experience has been at the university, but I know at Mayo, we've still generally gone with the surgical mask and eyewear for most care settings, with N95s for aerosol generating procedures and other high risk situations. I think that's the case for many places around the country. And at least in our experience, we felt that actually is reasonably adequate to protect healthcare workers. So in summary, persons infected with respiratory viruses generate respiratory droplets with a range of sizes and dispersal patterns. The infectious dose is important, which is governed by the various factors listed there. Ventilation is important. Environmental factors probably play a role as well. The pathogen is important because if the pathogen is replicating in the upper respiratory tract, it's going to be much more likely to generate particles with virus in it than if it's replicating in the lower respiratory tract, as well as the binding site for the pathogen in the susceptible host. PPE and host immunity are also important too. So this is the challenge that we face, is how do we sort of put all of this together as we move forward in the future to try and do a better job with whenever the next pandemic comes along. Finally, I want to just point out that in my view, we need a better mask. We need a mask that provides better filtration, that's easy to use, doesn't necessarily need to be fit tested, potentially is reusable and reasonable at cost. And I'm happy to say that the federal government through BARDA has launched this mask innovation challenge. If you want to go to the website, you can see the people selected in phase 1 to move on to additional testing. Some innovative ideas there, and I hope through smart folks that know about material science and how to formulate things, that we can have some better masks that work in the future for what you see in the background, which is for the situation where we all need to protect ourselves, both in the healthcare setting and outside the healthcare setting. So we'll move on now to whole genome sequencing and characterizing the transmission of bacteria in the healthcare setting. This is a hospital outbreak of carbapenem-resistant Klebsiella pneumoniae. This was at the NIH Clinical Center in Bethesda. You can see the timeline in part A of the figure at the top. They had 18 cases and 11 deaths. There were persistent cases despite use of standard IPAC precautions. The WGS really helped kind of take what was in B section of the figure and then C section of the figure, which was kind of a confusing map of positivity and location, and really distill it down into the transmission chain that you see on the bottom right side. And the conclusions were that the outbreak was likely monoclonal, not surprisingly. But more surprisingly, the transmission actually occurred from 2 different anatomic sites from the same index patient. And there were at least 3 independent transmission events from that index patient that led to 2 major clusters. So much more clarity. This is another cluster of multi-drug resistant Sphingomonas coriensis that occurred also at the clinical center. You can see from the diagram, the dark shaded boxes are the cases. The light shaded boxes are other Sphingomonas species that were identified. They were able to take the clinical isolates over a 10-year period of time from 2006 to 2016, and also collect isolates from sinks. And what they found was that there was a clonal strain over an 11-year period, which was probably due to a pervasive reservoir in the hospital water system, likely related to water that had stagnated in the pipes of a newly constructed but as yet unused facilities, which were present here in 2004 and 2005. So with remediation strategies of free chlorine and hot water temperature, they were able to address this. Other recent examples from 2021 and 2022 are that were facilitated by whole genome sequencing was the discovery of bacterial infection with umbilical cord derived products used for various therapies, a very serious nationwide TB outbreak that was linked to a contaminated bone graft from a patient, extensively drug-resistant carbapenemase producing Pseudomonas associated with medical tourism, and a dialysis faucet, supply faucet as a reservoir for carbapenemase producing Pseudomonas aeruginosa. So the question is then, can we do this for more than just, outbreak investigation? And this study from the folks at the University of Pittsburgh looked at enhanced detection of clusters in their hospital, comparing their traditional cluster detection, which is shown in the first bullet, with this enhanced cluster detection, which combined whole genome sequencing through surveillance of multiple pathogens. You see many gram-positive and gram-negative organisms in the figure. The individual dots in the big part of the circle are individual cases. The clusters are represented in the middle of the circle with the darker dots. And what they were able to identify was 99 clusters with 66% where transmission routes could be identified. And the key point was through the sequencing and the machine learning, they were able to identify geotemporal clustering that was prime time. Maybe not yet. It needs to be more real time. This was not necessarily real time. But I think that there's certainly opportunities that this could aid our routine infection prevention activities in the future. At Mayo, we've been doing some study of WGS for Staphylococcus. There's this outbreak that we looked at with from 2016 to 2017. The key point was that what looked to us as a bunch of MRSA, when we are actually able to do the WGS, we were able to understand that there were 2 major clusters, group 1 in the upper left and group 2 in the bottom right, that were occurring contemporaneously over multiple months. So it was a mixture of both group 1 and group 2. And as you can see, that only a minority, 8 of the isolates were unrelated to any other isolate. We did some culturing of healthcare workers in this one and identified 3 that were in group 1, and through a variety of different remediation efforts, we're able to get this under control a bit better. But we moved on to studying methicillin susceptible Staph aureus in the NICU in the next couple of years. And this is important because as the burden of disease is actually substantially higher for MSSA than it is MRSA. And we had 67 isolates analyzed over that period of time, 58% were isolates that were related to another isolate. But as you can see, there were many more groups, 11, and with variable numbers in each group, and some were very small. And a full 41% of the isolates were unrelated to any other isolates. So, you know, what's going on here, it's not all just due to patient-patient transmission, which was the case for our MRSA situation. So this work is still in progress. We're looking now at MRSA and MSSA over a 4-year period of time. We're trying to understand the effect of a move to a new unit with single beds primarily and a few doubles for twins, and dissect the geotemporal factors, so date and bed space, in relation to the number and type of allelic differences over time. And again, just some data from our 2021-22 experience. For MSSA, you can see a lot of different diversity in terms of the genetic aspect of it. Okay, finally then, innovations in study design. I had the good fortune to do some work with what's called the ARLG, Antimicrobial Resistance Leadership Group. In that group, a leader statistician by the name of Scott Evans has proposed some advances in study methodology, which in clinical infectious disease in 2015, where he described two components to study design: the desirability of outcome ranking and the response adjusted for duration of antibiotic risk, which we were then able to use in study design. I'll show you how that worked. I was fortunate with some colleagues to be able to lead this short course outpatient therapy of community-acquired pneumonia trial, where we compared short course therapy, where patients were randomized shortly after their diagnosis to then either complete the 5 days of treatment and then 5 days of placebo afterwards. That was short course, versus standard course, which was the 5 initial days that they got at their diagnosis plus 5 additional days of the same antibiotic for a total of 10 days. Now, typically this would be done as a non-inferiority study. So is short course non-inferior to standard course? What we were able to do using Scott's methodology is actually design it as a superiority study. And the way we did that was by bringing in a couple of the concepts that he had about how to design and analyze the study. And key to that is this desirability of outcome ranking, which is a ordinal outcome table, which combines the various things that you would care about in a course of treatment. So was there a clinical response? In other words, did the patient respond to the treatment that was given initially, or did they have to have additional ED visits or hospitalization? Second, was there a resolution of the pneumonia symptoms? Yes or no? And then finally, what were the adverse events that the patient experienced? You can see in row 1, which is the most desirable, adequate response, resolved symptoms, no adverse effects. The way we designed the table was that there would be increasing adverse effects in rows 2, 3, and 4. And then the bottom rows were really patients that didn't respond well to the treatment. And so by constructing this ordinal outcome table, you are able to characterize the experience of each patient in terms of all the things that happened to them in relation to their antimicrobial treatment. And then the response adjusted for duration of antibiotic risk is shown here. Touch complicated, but I'll walk you through it. Basically, there's 2 rules. And the first is you rank each participant by their overall experience using rule number 1, which is when comparing 2 participants with different door ranks, the participant with a more desirable door rank has a higher rank. So if you were in rank 1, you were ranked higher than if you were in rank 2 or 3, okay? Because rank 2 or 3, you had some adverse effects that are associated. The second thing is when you compare participants with an identical door rank, the participant with fewer reported days of antibiotic received a higher score. So if you were in rank 1 and you got 5 days of antibiotic, you were ranked higher than the patient in rank 1 who got 8 days or 10 days of antibiotic. The point being that if you can achieve the same clinical outcome with fewer days of antibiotic, that's advantageous. So this shows the ranking in the actual results. I won't go through it in detail, but you can see in the middle, there really wasn't much difference between short and standard course in terms of the ranking, according to the ordinal outcome table. When we brought the antibiotic part into it, then and calculated the probability of a more desirable response, the short course was superior. And so the advantageous from that standpoint. We also did a resistance profile testing with the short course shown in the red, and blue is the standard course. And you can see that even with this relatively simple trial and not long courses of therapy, the total resistance genes and beta-lactam resistance genes were lower in the red, the short course, than they were in the blue. So then these are some additional ARLG studies that are using desirability of outcome ranking for various kinds of stewardship studies, looking at ceftazidime, avibactam, vancomycin, and some additional ones that are planned in the future. And I'm sure we'll see more of this as we move forward. And finally, I had the opportunity to work with the ARLG folks again on thinking about how we could use adaptive designs for clinical trials and apply them to healthcare epidemiology research. Adaptive designs are not new, they've been around, but we haven't really applied them much to healthcare epi research. Adaptive designs are useful because they use data that accumulate during the study to modify study elements in a pre-specified manner. The idea is that they can provide flexibility to the trial so that the trial can actually succeed as a definitive test rather than being inconclusive, and preferably also in a shorter time frame involving fewer human subjects and at lower cost. And in the publication, we provided some examples for designs to address research questions related to infection prevention, treatment of antimicrobial resistant bacteria, and stewardship. So that's the conclusion of my presentation. I want to thank you again very much for the opportunity to come and speak with you. I welcome your questions and comments, and if you want to contact me afterwards, there's my contact information. So again, thank you so much. Is there anything in the chat?
For our home audience, go ahead and put things in the chat or Q&A, and I'll read them out for Dr. Huskins.
Dr. Slice, thank you.
Charlie, thanks so much. That was a great talk. You reviewed the data really nicely, and it's not terribly convincing that N95s really are that much better than surgical masks. And I wondered, and yet that's sort of the popular perception generally, and among healthcare providers, including myself. So I don't know, can you comment a little further on that?
I think the point is, and that's partly why I presented the experimental study, is that there are times that I think the risk is high, and they really are required. Because if you have an aerosol that is really a small particle aerosol and it's in high concentration, the surgical mask may not be adequate to protect you. I think the problem for us is that we have kind of assumed we need to use them all the time, everything. And that's probably not necessary. That's not, the lived experience that we've had at Mayo. I don't know what the university, has been, but I think that's not an uncommon scenario, that actually we've been served well by the general approach of surgical masks and other PPE for the majority of patient interactions. What we haven't, I think the challenge for us as we move forward is not to just say aerosol generating procedures, because we're defining it by the procedure, not necessarily by the risk. We need to do a better job of understanding the risk and being able to quantify that to understand best when it could be done. And then that's really my point about masks. We need a mask that we could use more universally. And maybe that's kind of pie in the sky, but we have this dichotomy of masks now, and one that's easy to use, simple, probably works pretty well, and one that's works better, but it's not so easy to use. And if you're going to use it correctly, it needs to be fit tested, and it needs to be used in the right way. But from my perspective, we need to try and reserve that for when it's truly needed, as opposed to all the time. But and that's a little bit different in the hospital setting than the community too, because in the hospital setting we have the advantage of in general better air handling than you might in many community settings. And air is important because if you have closed space, not good ventilation, you're going to have greater concentrations of those small aerosols, which potentially could be more of an airborne spread than a droplet spread. So if we had a better mask that we could use in that situation, I think that would be critical as well.
Got a couple of questions coming in from the chat. Here's one from Bill Pompucius. Would you comment on the negative effects of double masking, surgical mask over N95?
I'm not quite sure what you mean by negative effect. I think it's harder to breathe, probably.
Or maybe just comment generally on an N95 with a surgical mask over it. In what scenario would that be necessary or recommended?
I would probably do it the opposite, which is to do your surgical mask over the N95, because the surgical mask can protect against a fair bit and also protect against surface contamination of the N95. Yeah, and then the N95 is kind of the last barrier before your respiratory tract with the best filtration. And so I'm not recommending. I'm just
An N95 on top?
no. I mean the N95 first, and the mask on the surgical mask on top of that.
And then we just have a note of thanks from a member of the Wanamaker family on behalf of the children and grandchildren of Dr. Lewis Wanamaker. We want to thank you for doing this lecture. We appreciate Dr. Kaplan and Dr. Ferrari for continuing to organize this lecture and honoring our dad and granddad. That's nice.
Thank you very much.
I think we have time. I'll ask one more question. I always get to have the mic. I'm just curious to hear like 1 or 2 minutes on human factors and complying with PPE, like the study that said people still got it even though they had eye protection and surgical mask. But there's like wearing it and then there's really wearing it. So what's the best way to really understand if people are doing what we tell them to do in terms of PPE?
Yeah, well, we dealt with this when we were dealing with Ebola a few years ago, where, donning and doffing, remember those terms, became very common, and the appropriate way to don and doff is important. It's not actually easy to do or remember. I struggle, a little bit myself. It's like, okay, did I do that in the right order? So in that kind of critical situation, you really need to have. That's why we had observers for Ebola, to make sure that people were doing it correctly. With it's not taking things off is important. I mean, that's more important so you don't contaminate yourself. I think what I thought you were getting to also was kind of the bigger societal thing of how do we deal with society in the community of are we going to wear masks, are we not going to wear masks? I did have a slide in there. I decided in the interest of time I probably wouldn't crack open that but I think that's important. I know I was not at the ID Week meeting just a few weeks ago, but I know that's on the mind of public health and infectious disease physicians is how do we do a better job of communicating? Because I think we can all acknowledge that the communication and the messaging was not the greatest, and in part confused by the circumstances. But also we need to be able to convey critical public health messages more effectively and explain the rationale, just not, you must do this, not just a mandate, but why it's important. Whether that's going to be successful it's always, it's not going to be universally successful, but I think we could do much better than we have done.
Great.
Thank you.
Well, thank you so much. Thanks to our virtual audience. Yes, Dr. Kaplan.
I have one more quick personally related question. In the short-term versus long-term studies of antibiotics, did you find any difference between individuals who had been pre-treated with multiple antibiotics versus those, no matter whether they were short or long-term, those who had not seen other antibiotics?
I think, I think antibiotic exposure makes a difference. One of the things that, we did in the Scout Cap trial was we looked at the resistome. Now, we weren't looking at, we weren't pulling out isolates. It was not a specific, we weren't looking at pneumococci. We were looking at that bacterial populations in general and the resistance genes in the population. And what we found that there was a difference there. Now, how significant that is for that short a period with a pathogen like pneumococcus, not clear. But I think we know from other work that the more antibiotic exposure you have, the more likely that you are to, harbor organisms that carry the genes that lend to antimicrobial resistance. So, we always want to make sure that we're treating infections effectively. That's point number one with stewardship. But number two, to use them wisely. And hopefully, through some of the innovations in study design, we can get at that a little bit better. So we understand the full impact of what antibiotics do for patients, not just did it work to cure the infection, which is what we've kind of traditionally done.
Thank you.
All right, well, thank you to our virtual audience. That was up near 80 people today. Thanks to our in-person crowd. If you were here, there was delicious Panera breakfast. Sorry you missed it. For those who are virtual, have a great day, everybody. And thanks to Dr. Huskins for being here.
Thank you again so much for the invitation and the opportunity to speak with you and the opportunity to come home.